My name is Rachel Sullivan and my partner is Caroline Warren. We are both senior student registered nurse anesthetist. We are pleased to present our findings from our systematic review, which explores the optimal dose of intravenous dexmedetomidine to prevent delirium in elderly patients undergoing general anesthesia. Throughout the presentation, we will share the results of our systematic review, discuss relevant literature, and highlight the clinical implications of our findings. Postoperative delirium is one of the most common neurological disorders affecting elderly surgical patients, with significant consequences including longer hospital stays, higher healthcare costs, and even increased mortality. Patients can experience hypoactive or hyperactive symptoms and sometimes a mixture of the two. Hypoactive symptoms can include decreased motor function and depression, while hyperactive symptoms can include aggression and agitation. In addition, behavior, cognition, and sleep disturbances can occur. These causes are complex but are believed to involve neuroinflammation, neurotransmitter disruptions, and even vascular events during surgery. Dexmedetomidine is an alpha-2 adrenergic agonist. It is a sedative that provides analgesia while preserving respiratory function. Its mechanism includes stimulation of presynaptic receptors in the locus coeruleus, promoting natural sleep patterns and reducing catecholamine release. Importantly, it combats surgical stress-induced neuroinflammation by affecting microgilial activity through the MAPK-ERK pathway and vagus nerve stimulation. However, dexmedetomidine can cause hypotension and bradycardia, so careful dosing is essential to maximize delirium prevention while maintaining hemodynamic stability. The objective of this systematic review was to determine the optimal intravenous dose of dexmedetomidine to prevent postoperative delirium in elderly patients undergoing general anesthesia while maintaining a safe hemodynamic profile. Although previous studies have shown dexmedetomidine's potential to reduce delirium, the most effective and safest dosing strategy remains uncertain. The question is particularly important because as the elderly population grows, a greater proportion of surgical patients will be older adults. The objective of this
In this systematic review, the focus was on elderly patients aged 60 years or older undergoing general anesthesia. Patients receiving other forms of anesthesia, such as regional or neuraxial techniques, were excluded to maintain consistency. The interventions included studies that administered intravenous dexmedetomidine either before or during surgery. Studies using other routes of administration, such as intranasal or intrathecal administration, or the use of dexmedetomidine postoperatively were excluded. For comparisons, studies were selected that compared various doses of IV dexmedetomidine either to each other or to a placebo, specifically normal saline. Studies that compared dexmedetomidine to other sedative drugs were excluded to keep the focus strictly on dexmedetomidine's dose-response relationship. Primary outcome measures focused on the prevention of postoperative delirium or cognitive dysfunction, while studies focusing on outcomes like analgesia or hemodynamic changes were excluded. Finally, the types of studies included were 2 randomized controlled trials, a single-center pilot analysis, and 1 prospective quasi-experimental study. No relevant cohort studies were found. Case studies, systematic reviews, and meta-analyses were excluded. An exhaustive, systematic search of the literature was conducted by 2 doctoral nurse anesthesia students during August and September of 2024. The search engines utilized were Medline Complete, Central, CINAHL, ProQuest, Embase, and Ovid. The search terms used for Medline Complete, CINAHL, and ProQuest included general anesthesia spelled 2 different ways, GA, intravenous dexmedetomidine, Precedex, dexmedetomidine, dexmedetomidine hydrochloride, dosage, dosing, dose, postoperative delirium, POD, surgery delirium, postoperative cognitive dysfunction, POCD, and postoperative confusion. The search terms used for Central, Embase, and Ovid included general anesthesia spelled two different ways, GA, intravenous dexmedetomidine, intravenous Precedex, intravenous dexmedetomidine hydrochloride, dosage, dose, dosing, postoperative delirium, postoperative confusion, postoperative cognitive dysfunction, POCD, postoperative delirium, POD, and surgery delirium. Search expanders in CINAHL, Central, and Medline Complete were apply-related terms and apply equivalent subjects. The expander include spelling variants for search terms was utilized in ProQuest. No search expanders were used in Embase or Ovid. The Boolean phrase OR was used to combine and expand the searches in all databases. The date range limiter for all utilized databases was 2004 to 2024. The search limiters for CINAHL included peer-reviewed, English language, aged 45 to 64 years, aged 65 plus years, aged 80 and over, and all adults. The search limiters used for Medline Complete include peer-reviewed, English language, aged 45 to 64 years, middle-aged plus aged 45 plus years, aged 65 plus years, aged 80 and over, and all adults 19 and up. Search limiters for ProQuest and Central included peer-reviewed and English language. Search limiters for Embase included middle-aged, which was 46 to 65 years, age 65 and up, and very elderly, which was age 80 and over. The two students conducting the research met with a university librarian to ensure that the search and its results were complete and concise. A total of 2,073 articles were yielded, 2,067 of those from the literature search, and an additional 6 articles from Google Scholar and references of related articles. 2,073 articles were identified from the literature search. 20 articles were excluded due to being duplicates or retracted articles, leaving the total at 2,053 articles. These articles were screened for inclusion and exclusion criteria. Studies were included if their title or abstract appeared to contain elderly patients undergoing general anesthesia who received intravenous dexmedetomidine to prevent postoperative delirium. In total, 2,037 articles were excluded before full text retrieval due to their lack of encompassment of all parts of the research question. 10 articles were retrieved in their full text form from their respective databases. Additionally, 6 articles were identified from citation searching that were sought for full text retrieval. 2 of those 6 articles sought for full text retrieval from citation searching were unable to be retrieved in their entirety or in the English language. Therefore, 14 articles were assessed for eligibility in their full text format. Of these 14 articles, 9 were excluded based on the exclusion criteria derived by the students. The 5 remaining articles were critically appraised via the Joanna Briggs Institute checklist. After all appraisal of all articles, it was mutually decided between the 2 doctoral students that 1 article should be excluded for its lack of validity. In conclusion, 4 articles were included in the final systematic review.
Fang and colleagues conducted a single-center pilot analysis in China to evaluate the optimal intraoperative dexmedetomidine infusion rate to prevent cognitive dysfunction in elderly cardiac surgery patients. The study included 88 participants, all between the ages of 60 and 75. Group L, also known as low group, was assigned a dose of 0.1 to 0.5 mics per kg per hour. Group H, also known as high dose, utilized a dose of 0.5 to 0.9 mics per kg per hour. The study collected extensive data including demographic information, medical and surgical history, anesthesia medications, and cognitive function. MMSE scores on postoperative day 2 were the primary outcome. Postoperative MMSE scores were significantly lower in the high-dose group. Additionally, Group L experienced fewer incidents of hypotension and bradycardia. Notably, cognitive scores declined immediately after surgery but began to improve by day 3. Fang loading dose followed by various continuous infusion rates of dexmedetomidine was assessed through 2 researchers, Li and colleagues, and also Zhang and colleagues. Li and colleagues was a randomized controlled trial in China, while Zhang and colleagues is a prospective non-randomized study. Both examined cognitive outcomes and inflammatory markers. The population was elderly patients undergoing spinal surgery under general anesthesia. Li and colleagues split 120 participants into 4 groups: Group S, Group M, Group L, and Group C. Group S utilized a dose of 0.2 mics per kg per hour. Group M utilized a dose of 0.5 mics per kg per hour. Group L utilized a dose of 0.8 mics per kg per hour, and Group C utilized a placebo of normal saline. The results showed that cognitive function was better preserved in the medium and high dose groups, with Group M offering the most favorable outcomes without significant hemodynamic compromise. Inflammatory markers were also decreased more rapidly in Groups M and L. On the other hand, Zhang and colleagues divided 165 participants into 3 groups: Group A, Group B, and Group C. Group A utilized a continuous infusion dose of 0.5 mics per kg per hour, while Group B utilized an infusion dose of 1 mic per kg per hour, while Group C was a controlled group that utilized normal saline. Zhang studied utilized a prospective, non-randomized design. It focused on cognitive outcomes and biochemical stress responses, comparing different dexmedetomidine infusion rates to a placebo group. Group B showed the most favorable outcomes, which was the infusion rate of 1.0 mics per kg per hour. This group showed the lowest stress markers and highest MMSE scores, significantly reduced propofol use. It did also show the most stable hemodynamics. Group A also improved outcomes over control, but less than Group B. Group C had the highest inflammation and lowest cognitive scores. Group B stood out for its superior outcomes, better MMSE scores, lower inflammatory markers, and more stable vital signs. Group A showed some benefit, while the control group fared worse outcomes across all measures. Li and colleagues conducted a double-blind randomized controlled trial to examine how the timing and dosage of intravenous dexmedetomidine affects postoperative delirium in elderly patients undergoing laparoscopic non-cardiac surgery. A total of 354 patients aged 65 or older were included and randomized into 3 groups. Group D1 received a bolus of dexmedetomidine at anesthesia induction, followed by a continuous infusion. Group D2 received the same bolus but 15 minutes before the end of surgery. Group S served as the placebo group and received normal saline. This study identified that a 1 mic per kg bolus followed by a continuous infusion of 0.2 to 0.7 mics per kg per hour of dexmedetomidine reduced the incidence and duration of postoperative delirium when compared to a single 1 mic per kg bolus of dexmedetomidine without an infusion.
Based on the conducted research, it has been demonstrated that medium-dose and high-dose infusions of intravenous dexmedetomidine are more successful at preventing postoperative delirium in the elderly population undergoing general anesthesia than a low-dose infusion. High-dose infusions, however, demonstrated an increased rate of complications, such as bradycardia, hypotension, and increased recovery lengths when compared to medium-dose infusions. Because of this, the proposed research question was unable to be definitively answered, as more research needs to be conducted regarding the optimal dose of dexmedetomidine that not only prevents postoperative delirium, but also does not cause intraoperative hemodynamic adverse effects. Since the articles each had a different dose range that was considered low dose, medium dose, and high dose, future research needs to provide a more specific range that can prevent postoperative delirium. As far as limitations are concerned, one major limitation of the systematic review is the lack of variety of studies included. This review included 2 randomized controlled trials, 1 prospective quasi-experimental study, and 1 single-center pilot analysis. While the randomized controlled trials and the single-center pilot analysis utilized randomization procedures, which lend to the validity of the study, the prospective quasi-experimental study did not use randomization for participant allocation, which can lead to concerns for a lack of internal validity and potential for bias. Another limitation involves the anesthetic protocol for each study. All of the studies utilize a different anesthetic technique. For example, Some studies use total intravenous anesthesia, while others use volatile anesthetics. Just like limitations, there were also strengths to this systematic review. One strength was the fact that all participants throughout all of the studies had similar patient characteristics. While the studies may have used all different techniques when performing their general anesthetic, they were consistent in the fact that only the variable that was changed between the control and intervention groups was the administration or various dosing of dexmedetomidine. All of the articles were from scholarly journals, and 3 of them provided level 2 evidence, while the 4th provided level 3 evidence. Additionally, the incidence of postoperative delirium was assessed through the MMSE or CAM scales. Lastly, multiple forms of statistical analysis were used in each study. There were 2 major challenges noted in the systematic review. The first challenge was that while higher doses of dexmedetomidine were shown to demonstrate lower incidence and duration of postoperative delirium, it was also the dose range that was shown to demonstrate the highest amount of hemodynamic consequences, such as hypotension and bradycardia. The other challenge associated with this systematic review is that only 2 of the articles, conducted by Lee et al. In 2021 and Zhang et al. In 2020, studied similar dexmedetomidine dosing ranges. It is recommended that more research is conducted regarding the optimal dose of intravenous dexmedetomidine that can prevent postoperative delirium in the elderly population undergoing general anesthesia. A balance must be found between the dose that can achieve delirium prevention and a dose that does not cause hemodynamic consequences intraoperatively. Also, since each study considered a different dose range as low dose, medium dose, and high dose, additional research should be conducted to identify a more specific dose range that is ideal for postoperative delirium prevention. The literature recommends using a medium dose or high dose infusion of dexmedetomidine intraoperatively to mitigate postoperative delirium in the elderly. Before selecting a dexmedetomidine infusion dose, practitioners should evaluate patients' medical histories, focusing on cardiovascular function and hemodynamic stability. At higher doses, dexmedetomidine is associated with bradycardic and hypotensive episodes. In addition, providers should slowly titrate the dexmedetomidine dose in response to the patient's hemodynamics. Additional research is required to identify the optimal intravenous dosing method, whether that be a continuous infusion, bolus dosing, or loading dose followed by continuous infusion, as well as the appropriate time of administration within the perioperative phase.